Case study 12 talks about a cholecystectomy. GL, a 42-year-old obese Caucasian woman, entered the hospital with nausea and vomiting, flatulence and eructation, a fever of 100.5 degrees Fahrenheit, and continuous right upper quadrant and subscapular pain. Examination on admission showed rebound tenderness in the RUQ with a positive Murphy sign. Her skin, nails, and conjunctiva were yellowish, and she complained of frequent clay-colored stools. Her leukocyte count was 16,000. An ER, CP, and ultrasound of the abdomen suggested many small stones in her gallbladder and possibly the common bile duct. Her diagnosis was cholecystitis with cholelithiasis. A laparoscopic cholecystectomy was attempted with an intraoperative cholangiogram and common bile duct exploration. Because of GL's size, some of the unexpected bleeding visualization was difficult, and the procedure was converted to an open approach. Small stones and granular sludge were irrigated from her common duct, and the gallbladder was removed. She had a T-tube inserted into the duct for bile drainage. This tube was removed on the second postoperative day. She had an NG tube placed before and during the surgery, which was removed on day 2. She was discharged on the 5th postoperative day with a prescription for PRN pain medication and a low-fat diet. Case study 12-2, surgical pathology report. Gross description: the specimen is received in formalin-labeled ruptured duodenal diverticula and consists of enteric tissue measuring approximately 6.3 by 2.8 by 0.7 centimeters. The serosal surface is markedly dull in appearance and fibrotic. The mucosal surface is hemorrhagic. Representative sections are taken for microscopic examination. Microscopic description: sectioned slideshow segments of duodenal tissue with areas of gangrenous change in the bowel wall and acute and chronic inflammatory infiltrates. There are chronic and focal acute inflammatory cell infiltrates with hemorrhage and the mesenteric fatty tissues. There are areas of acute inflammatory exudates noted in the fatty tissue. Histopathological changes are consistent with ruptured duodenal diverticula. Case study 12-3, colonoscopy with biopsy. SM, a 24-year-old man, had a recent history of lower abdominal pain with a frequent loose mucoid stools. He described symptoms of occasional dysphagia, dyspnea, nausea, and aphthous ulcers of his tongue and buccal mucosa. A previous barium NEM showed some irregularities in the sigmoid and rectal segments of his large bowel. Stool samples for culture, ova, and spherocytes were negative. His tentative diagnosis was irritable bowel syndrome. He followed a lactose-free, low-residue diet and took Imodium to reduce intestinal motility. His gastroenterologist recommended a colonoscopy. After a 2-day regimen of soft to clear liquid diet, laxatives, and an enema the morning of the procedure, he reported to the endoscopy unit. He was transported to the procedure room. ECG electrodes, a pulse oximeter sensor, and a blood pressure cuff were applied for monitoring. An IV was inserted in SM's right arm. An IV bolus of Demerol and a bolus of Versed was given. An SM was positioned on his left side. The colonoscope was gently inserted through the anal sphincter and advanced proximally. SM's was instructed to take a deep breath when the scope approached the splenic flexure and the hepatic flexure to facilitate comfortable passage. The physician was able to advance past the ileocecal valve, examining the entire length of the colon. Ulcerated granulomatous lesions were seen throughout the colon with concentration in the sigmoid segment. Many biopsy specimens were taken. The mucosa of the distal ileum was normal. Pathology examination of the biopsy samples was expected to establish a diagnosis of IBD. The case study questions. Number 1. Flatulence and eructation represent E. Sounds heard only by abdominal ejaculation. Number 2. Murphy sign is tested for D under the ribs on the right. Number 3. The NG tube is inserted through the nose and terminates in the stomach. Number 4. Enteric tissue is found in C, the esophagus. Number 5. The mucosal surface of a digestive organ is the inner surface, D. Number 6. Diverticula are small pouches in the wall of the colon. Number 7. Dysphagia and dyspnea are difficulty or pain with C, swallowing and digestion. Number 8. The buccal mucosa is the B mouth inside of the cheek. Number 9. A gastroenterologist is a physician who specializes in the study of C, stomach, intestines, and related structures. Number 10. The splenic and hepatic flexures are bends in the colon near the D, spleen, and liver. Number 11. Intestinal motility refers to chewing, which is A. Number 12. A colonoscopy is an endoscopic examination of the large bowel, which is letter E. Number 13. The ileocecal valve is EBND, which is at the distal ileum and near the appendix. For number 14, write the meaning of each of the following abbreviations. 14, ERCP, which stands for endoscopic retrogauge cholangiopancreatology. Number 15, RUQ is upper eye quadrant. Number 16 is NG, nasogastric, NASOGASTRIC. Number 17 is inflammatory bowel disease, IBD. And 18 on, pertaining to the first part of the small intestine, is the duodenum. Number 19, pertaining to the membrane that supports the intestine, mesentery. Number 20, localized, is cancer. 21, fluid that escapes from blood vessels as a result of inflammation, is effusion. 22, presence of hidden or microscopic blood, is hematuria. Number 23, jaundice, yellow skin. 24, drug that treats nausea and vomiting. I had put meslazine, MECLIZINE, and which is also known as hydrochloride. And I also put Dramamine. The following question: 25, stones in the gallbladder are known as gallstones. 26, endoscopic surgery of the gallbladder is known as a laparoscopic cholecystectomy. Inflammation also means swelling for number 27. Number 28, radiographic study of the gallbladder and biliary system, a cholecystography and cholangiography. Number 29, ring of the muscle that regulates the distal opening of the colon is the pyloric sphincter. And number 30, the surgical excision of tissue for pathology examination is known as a biopsy.